Assalamu alaikum. This is the presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is epistaxis. Epistaxis is defined as bleeding from inside the nose. So, if we see, whenever the bleeding it occurs from inside the nose or nosebleed, it is known as epistaxis. Introduction. Epistaxis can be seen in all age groups, but its peak is usually seen in 2 to 10 years in children and in old age people. It usually presents as an emergency. In majority of the cases, the bleeding is in small quantity. It is self-limited or can easily be controlled with simple measures. However, sometimes it can be intense and life-threatening. The important thing to see is that the epistaxis is a sign and not the disease. So, always try to find the cause and treat the cause. In most of the cases, once the cause is treated, the epistaxis will be stopped. Nose has a rich blood supply. The nasal septum and the lateral nasal valves with its blood supply and two plexus in this region can lead to epistaxis. It is supplied mainly by both the internal and the external carotid systems, with Cardiovascular plexus in the Little's area and the Woodruffs plexus. So, the blood supply of nasal septum, the internal carotid system include both the anterior and the posterior ethmoidal arteries, which are branches of ophthalmic artery, while the external carotid system includes the sphenopalatine artery, which is the major supply, while the others are the greater palatine and the superior labial artery, which are branches of maxillary artery and facial artery respectively. The blood supply of the lateral wall, again the internal carotid system includes the anterior and the posterior ethmoidal artery, while the external carotid system here includes the posterior lateral nasal branches from the sphenopalatine artery, greater palatine artery, branch of the maxillary or internal maxillary artery, the nasal branch of the anterior superior dental, which is branch from the infraorbital branch of the maxillary artery, then branches of the facial artery to nasal vestibule. It is very important to know which arteries or are the main supplying ones in the nose, as one treatment is ligation of arteries. So, unless we know which arteries are supplying, which arteries are giving the major supply, we can not perfectly control the disease. So, this is the picture representation of the nasal septum, artery supplying to the nasal septum. This is the picture representation of the artery supplying the lateral nasal wall. So, Little's area, the plexus formed in the little area is known as Cardiovascular plexus. This area is present at the anteroinferior part of the nasal septum. The arteries which anastomose in this area are the anterior ethmoidal artery, septal branch of superior labial artery, septal branch of sphenopalatine artery, and septal branch of greater palatine artery. This is the most common site of epistaxis. Due to the drying effects of the inspiratory current, the air we inspire, and the fingernail trauma. These are the most two common causes of epistaxis in this region. So, this is the Little's area, this is the vestibule, and just in the behind the vestibule in the anteroinferior part, this is the Little's area. So, this is the vessels which is bleeding. Here the bleed is more, here it's just start to, because a little sneeze or a scratch, it will start to bleed. Same here, but here it is actively bleeding. Woodruffs area. So, the Woodruffs plexus is formed in the Woodruffs area. This is the vascular area under the posterior end of inferior turbinate. Posterior end of inferior turbinate. It is formed by the plexus of sphenopalatine artery and the posterior pharyngeal artery. This is the area for the posterior epistaxis. So, this diagram, it is showing the Little's area and the vessels involved in that, and the Woodruffs area and the vessels involved in that. Imax is basically internal maxillary artery, ICA is internal carotid artery. Internal maxillary and maxillary is the same. So one more vessel which is responsible, this is not the artery but a vein, retrocolumellar vein. So these pictures are basically to show you what is the columella. So this is the nasal tip, and the one joining the nasal tip with the skin above the upper lip, this is the columella. So retrocolumellar vein is just posterior to it. This vein runs vertically down behind the columella. It crosses the floor of the nose and joins the venous plexus on the lateral nasal wall. This is the common site of venous bleeding in young adults. Most of the bleeding from nose is arterial, mind this thing. So causes can be divided into local causes involving both the nose and the nasopharynx, then general causes, and idiopathic. 30% of the cases can be idiopathic, where no causes were seen. So the local causes in the nose, they include trauma, commonly the fingernail trauma, injuries of the nose, accident, sports injuries, fractures, or any intranasal surgery, etc. Infections, acute viral, including the viral rhinitis, acute sinusitis, diphtheria, etc. Chronic includes the atrophic rhinitis, tuberculosis, syphilis, and septal perforations or granulomatous lesions. Then foreign bodies involving the non-living, any neglected foreign body or a rhinolith, it can give rise to epistaxis, or a living foreign body like maggots or leeches. Then neoplasms of the nose and paranasal sinuses, benign including the hemangioma or papilloma, and malignant any carcinoma or sarcoma. Then atmospheric changes like high altitude, sudden decompressions in Cassens disease, and deviated nasal septum. In nasopharynx, it includes the adenoiditis, adenoid hyperplasia, infection of adenoids, juvenile nasopharyngeal angiofibroma. This is the most common cause of epistaxis in teens from 10 to 20 years of age in male children. So any patient presenting in this age group with recurrent epistaxis, always rule out juvenile nasopharyngeal angiofibroma. And malignant tumors in the nasopharynx can also present with epistaxis. So if we look at the picture representative, this is DNS, this is the spur. So if you can see closely, these are the blood vessels which are stretching. So once these blood vessels they stretch, there is very chance that it can bleed. So this type of DNS can also give rise to headaches also, as this spur it is impinging on the inferior turbinate. Here if you can see the inferior turbinate, it's all congested, the mucosa of the nose is congested. So in active or acute infections, again there is chance of bleeding. So here it is a septal perforation, the crust will form and then bleeding can occur. In this picture also, if you can see, again the septal spur posteriorly lying, here it is anteriorly, here it is posteriorly lying, but again wherever spur type DNS is present, epistaxis can occur. And this is, if you see, this is the inferior turbinate, nasal septum, and there is some mass here. So this is the angiofibroma, juvenile angiofibroma, as I saw that it's a vascular tumor and it bleeds like hell. So general causes includes first the cardiovascular system, including the hypertension, and this is the most common disease or presentation in old age epistaxis. Most of the 90% of the patients in old age who presents mainly have high blood pressure. Then arteriosclerosis or hormonal changes like in pregnancy. Then bleeding disorders like hemophilia, leukemia, thrombocytopenia, liver disease includes hepatic cirrhosis, as there will be deficiency of factors 2, 7, 9 and 10. Kidney disease like chronic nephritis, drugs, patients on salicylates or anticoagulant. Tumors of mediastinum, it will lead to mediastinal compression, and that mediastinal compression raises the venous pressure in the nose, which can lead to epistaxis. Then acute general infections like influenza, measles, chickenpox, etc. and vicarious menstruation. Pathophysiology. Epistaxis occur due to rupture of blood vessels within the richly perfused nasal mucosa. As I already mentioned that nose is richly supplied by blood vessels, and you have seen from the blood supply of the nose, there are many arteries in this area. Secondly, nose is the first site from where the blood will ooze out throughout the body whenever there is low platelets, high blood pressure, because in cases where if in high blood pressure especially blood not comes out from the nose, then it will cause rupture of the arteries in the brain leading to stroke. Sites. Little's area is the most common site. In 90% of cases, bleeding occur from this site, then above the level of the middle turbinate. Bleeding from above the middle turbinate and corresponding area of the septum is often from the anterior and posterior ethmoidal vessels. So we see from the diagram the upper part of the nose, it is supplied by the anterior and the posterior ethmoidal arteries. Then below the level of the middle turbinate, it is usually comes from the greater palatine artery, and if we see epistaxis coming from the posterior part of the nasal cavity, then the main vessel is the sphenopalatine artery. Diffuse can be occur from both the septum and the lateral nasal wall. This is often seen in general systemic disorders and blood dyskaryosis, as local causes usually settle with simple measures and they are not too much severe apart from angiofibroma or any bleeding mass there, and from the nasopharynx. So classification of epistaxis, it is classified into anterior and the posterior epistaxis. Anterior epistaxis is defined when the blood flows out from the front of the nose while the patient is in sitting position, because if he is lying, then blood will definitely flow down into the throat. And posterior epistaxis is mainly blood flows back into the throat, and when you depress the tongue with the tongue depressor, you will see blood, it will be trickling down the posterior pharyngeal wall. Patient may swallow it and have a coffee colored vomitus, which can be misdiagnosed as hematemesis. So the difference between the anterior and the posterior epistaxis, as already mentioned, definition is the bleeding anteriorly from the nostrils, and posterior is the bleeding going down into the throat through quena. Incidence, anterior epistaxis is more common than the posterior epistaxis. Little's area or the anterior part of the lateral wall is the most common site, while in posterior epistaxis, posterior superior part of nasal cavity, and often difficult to localize the bleeding point in these cases as bleeding is diffuse. Then age, usually in children and young adult, while posterior epistaxis is more common above the age of 40 years. Trauma is the most common cause in anterior epistaxis, while in posterior epistaxis it is spontaneous due to hypertension or atherosclerosis. Then bleeding, mild bleeding can be controlled by the local pressure or anterior nasal pack, while in posterior epistaxis the bleeding is severe and requires hospitalization and the postnasal pack. Now the management. So the management, it is important that we should know little details about the history. So it is important to note and ask from the patient the mode of onset, whether it is spontaneous or any fingernail trauma or any sniffing or putting the things inside. Then what is the duration and frequency of bleeding, amount of blood loss, how many handkerchief or tissues are filled with the blood. Then which side the bleeding is occurring, either from both sides or one side, usually it is from one side of the nose. Then whether bleeding is of anterior type or the posterior type, any known bleeding tendency in the patient or in the family, then any history of known medical ailment like hypertension, cirrhosis, nephritis, etc., or any history of drug intake, whether patient is on salicylates or anticoagulants, etc. General measures. So in general measures, make the patient sit up with the backrest, reassure the patient. Keep a check on the pulse, blood pressure and respiration, and temperature also. Sometimes if the temperature is high, then also the bleeding will continue to ooze out. Then send the blood for grouping and cross match in severe cases, as patient may need blood transfusion. Maintain hemodynamics with crystalloids or colloids, or in severe cases transfusion of fat cells or FFPs, or depending upon the underlying cause. Then antibiotics. If the nose is packed, then it should be started. Intermittent oxygen, because if the nose is packed on both sides, then patient may not able to breathe through the nose, and in some patients we need to provide them with intermittent oxygen. Then important thing is to, after these general measures, investigate and treat the patient. Once the epistaxis is stopped, then investigate and treat the patient for any underlying local or general cause. So for this reason, we should know what causes can be there for epistaxis. Investigations mainly include the blood CBC. We have to look for the hemoglobin, RBCs, WBCs, and most important the platelets. Then bleeding time and clotting time, prothrombin time and activated partial thromboplastin time, blood grouping and cross match. And if we are suspecting any mass or any lesion, then maybe we have to perform CT scan for the nose and paranasal sinuses, like in juvenile nasopharyngeal angiofibroma, CA nasopharynx, nasal tumor. Treatment. The first line of treatment is the first aid. As already mentioned, the most of the times the bleeding, it occurs from the Little's area, so it can be easily controlled by pinching the nose with thumb and index finger for 5 minutes. This compresses the vessels of the Little's area. Or you can also give cold compresses, or people also used to put water on the head, but it should be cold, not hot, as it can cause vasoconstriction and stop the bleeding. Then second is the cauterization. So cauterization is useful in anterior epistaxis, because the most important thing to do the cauterization is to locate the bleeding point or identify the bleeding point. The area is anesthetized first with a pack of 4% xylocaine and 1% 1 in 1000 adrenaline mixture. Then after 5 minutes the pack is removed, and the area is anesthetized either with a bead of silver nitrate, which are the silver nitrate crystals, white crystals, they are there, you apply there, I'll show you in the picture, or it can be coagulated with electrocautery. Best is the bipolar diathermy or unipolar, but you need to cauterize that electrically. This thing is mainly done in the operating room, but if the machine is available in the OPD, then it can be done in as an OPD procedure. So this is the proper position. The patient should sit with backrest and lean forward and pinch the nose. This is how you have to pinch the nose, not in this area but in the vestibule area, and you have to tightly pack it for 5 minutes. In children, the child may have to sit on the lap of a parent or any adult, and then that adult will pinch the nose, and head should be tilted. If the head is tilted backwards, all the blood will ooze out. Definitely in this condition also, as blood will take some time to stop, so small blood may trickle down the throat, but with this all the blood will go down straight. So this is not the position, this is the right position. You have to advise this to the patients. Then so if you see in this picture, this is the nasal septum, this is the inferior turbinate, this is middle turbinate. So this is the bleeding point. Sometimes when you anesthetize, it will clear out this diffuse area, and only a spot from where the actual bleeding is occurring, it comes in view, because we have to visualize that exact spot to cauterize this. Okay, so this is the application of the silver nitrate. From here the bleeding is there, and the silver nitrate is applied in the surrounding, and then it will cover itself this one up. So this is the bipolar cautery. This is the bleeding spot from where the bleeding is coming, and with these two prongs you press one above, one below, and then it will cauterize it. If the bleeding does not stop with simple pinching, or because if after pinching 5 minutes the bleeding is still very active, you will not able to localize. We have to skip the second step and come to this part, anterior nasal packing. This is usually done for profuse bleeding, since the site of bleeding is difficult to localize. So first what we do, we clear off the nose with any blood clots by suction. Then ribbon gauze. We take a ribbon gauze, we take the and soak it. So about 1 meter of the gauze, or 2.5 centimeter wide, is required for each nasal cavity. First few centimeters of the gauze are folded upon itself and inserted along the floor of the nose, and then whole of the nasal cavity is packed tightly by layering the gauze, layering the gauze from the floor to the roof, from before backwards. One or both nasal cavities may need to be packed. Pack is usually stays there for around 24 hours. Whenever you do the anterior nasal packing, it should stay there for 24 hours. So systemic antibiotics have to start it. If the patient is admitted, then we will start the IV antibiotics, otherwise we will give him oral antibiotics. So this is the equipment needed. This forceps is the main forceps, which is known as Tilly's forceps. The shape is such that, because if you use the artery forceps, the gauze will stuck inside, and once you put inside and bring out the artery forceps, the gauze will also come out. Then the gauze is folded upon, rolled up in this way that it becomes around 2.5 centimeter in width. Dry gauze should never be inserted. So you need to either soak it with liquid paraffin, or you can put it Polyfex antibiotic ointment, acryflavin, then there are some other solutions. So all of it should be dipped in that, and then you will place it in the nose in layers, folded upon itself, and so it should be tightly packed. If any area there is loose packing, then it will not control the bleeding. So we need to pack the nose tightly. So remember this thing, that this is a very painful procedure. It's not easy to do. So we try to control the bleeding with simple measures, but if packing is necessary, then we have to do this. Yes, there is one other way of anterior nasal packing which is less painful, and that is with Mirocell. So what we do, we just insert the Mirocell like this along the floor, and you put either the saline on it or the decongestant nasal drops, xylometazoline nasal drops, so it will swell up and it fills the nasal cavity. Posterior nasal packing. This is done for the patients in which the bleeding is occurring posteriorly into the throat. The proper postnasal pack, there are two types of postnasal packs. One, the proper postnasal pack with gauze roll and Y strings, but that should be done under general anesthesia and should be kept for about 3 days or 72 hours. While another quick method is with the Foleys catheter. Remember that after doing posterior nasal pack, anterior nasal packing is must to stay that area to control the anterior part as well. So a postnasal pack is first prepared by tying 3 silk ties to a piece of gauze rolled into the shape of a cone. A rubber catheter is passed through the nose and it is grasped with the forceps through the nasopharynx. Then we have to pass 2 rubber catheters from both sides of the nostril, and then the 2 strings which are tied, as I said, 3 strings are tied. So 2 strings, they will be applied to those two rubber catheters. The rubber catheter, then we push it out, the strings will come out, and with the hand we push this gauze roll into the nasopharynx, so it will stuck into the nasopharynx. Those strings, they are tied outside the nose, and the third tie, the base of the Y or the leg of the Y, that is coming out from the mouth, and it is taped outside on the cheek. So when we have to remove it, we will pull with that string which is coming out from the mouth, and the pack will come out. But we don't need any anesthesia for removal. This is the Foleys catheter. So with Foleys catheter, you simply pass the Foleys catheter into the nasopharynx, and once it is there, you inflate the balloon and tie a clip outside the nose, and then we do anterior nasal packing. Complications of the pack, it can lead to infection as it is a foreign body. This is one reason why we dip the anterior nasal pack in antibiotic cream. Secondly, we start the antibiotics to prevent this, because if the infection is severe, it will lead to toxic shock syndrome. And loose pack, or if you push the pack too much behind, it will fall into the nasopharynx or may obstruct the airway. Some special cases like hypertension, we need to control the blood pressure. The patient usually presents with severe epistaxis, but as soon the blood pressure returns to normal, the patient becomes totally fine, and on checking, it seems that he never bleed from the nose. Then hemophilia or any blood disorders, you replace, in hemophilia you have to replace the factor 8 or fresh blood. Then clotting deficiencies need FFPs, liver disease need FFPs, thrombocytopenia, you have to transfuse the platelets. If patient is on anticoagulants, stop the drug. Heparin is usually reversed with protamine sulfate, and warfarin with vitamin K. And in unconscious head injury patients, to do packing will be sometimes dangerous, as patient is unconscious, and the patient may not able to breathe from the mouth. So once the nose is packed, so special care or special attention should be given to such patients. Other methods, they include the endoscopic cauterization. It is again almost similar to simple cauterization, but with this we are better able to identify the bleeding spot. Then in some cases we need to elevate the mucochondrial flap or an SMR operation. Mucochondrial flap elevation will disrupt the blood supply to the septum, as all the blood vessels, they are in the mucoperichondrium. Then if these measures, they don't fail to stop the bleeding, then we may have to go for ligation of blood vessels. As I already mentioned in the start of my presentation, that it is important to know which are the main blood supply of the nose. So knowing those vessels, we can ligate them. With newer techniques and special equipment, the most terminal branches can be ligated, the major terminal branch like the sphenopalatine artery, which is come afterwards, the maxillary artery or the ethmoidal arteries. To ligate maxillary artery with simple instruments is difficult, as you have to open up the anterior wall of the maxillary sinus, then you have to drill out the posterior maxillary wall. Then just behind the posterior maxillary wall, there is pad of fat from which the vessel is moving. Then you need clips, vascular clips, to ligate these. So the quickest way to ligate any vessel is the external carotid artery. So this is the quickest way to control the bleeding or ligate the vessel. But you open up the neck at the level of the thyroid cartilage, but there two major vessels are placed, the external carotid and the internal carotid. So any blood vessel which is giving branches is the external carotid, as internal carotid has no branch in the neck. So the first branch is the superior thyroid artery, so you ligate the external carotid above the superior thyroid artery, and ethmoidal arteries can also be ligated. Then now latest technique is the transnasal endoscopic sphenopalatine artery ligation, TESPAL. The mucosal flap lifted in the posterior part of the lateral nasal wall. Sphenopalatine artery is localized as it exits the foramen and closed the vessel with vascular clips. Then again embolization is another technique. You will embolize the internal maxillary artery, as all these major vessels, they are branches of the maxillary artery. Thank you.